participation from all over state. I, Dr. Richa Gupta, Secretary of NIGF Rajasthan chapter, feel honored to be our moderator for this session. Today, we are meeting for a very relevant and clinically significant topic, residual ovarian syndrome. I take this opportunity to sincerely thank the NIGF national body for continuously supporting academic initiative at a state level. Now I invite Dr. Preeti Sharma, President of Rajasthan chapter, to introduce our patron and president and vice president, Dr. Taru Chaya. Dr. Preeti Sharma is the senior gynec consultant in Jaipur, in Cocoon Hospital and Surya Hospital, Jaipur. And she is a trainer of Foxy RSC and now received many awards and expertise in high-risk obstetrics, infertility, and advanced gynecology and laparoscopy. And she is president of Rajasthan NIGF chapter. Welcome, Dr. Preeti Didi.
Thank you, Richa. So, I'm really proud that NIGF Rajasthan has taken an initiative to spread this education among our colleagues, our obstetricians. And, even these small academic programs are going to help us to gain insight into many relevant day-to-day topics. So it's my pleasure now to welcome our guests of honor, Dr. Sharda Jain. She needs no introduction. And she is a very passionate academician and teacher, founder and Secretary General of Delhi Gynecological Forum, and founder and chairman of North India Gynecological Forum, and privileged to be a member of ethical committee from last 7 years. And we all look to her in awe and inspiration about the words she uses to guide us every day. Dr. Ragini Agarwal, our very own mentor and a great academician. As you see, her CV is so vast, but all I know is she's a very warm and affectionate person, and a really true teacher from the heart who will work along with us to take this NIGF forum to a bigger height. Welcome, Dr. Ragini.
Thank you so much, Dr. Preeti.
आपका CV पढ़ने की मेरी हिम्मत नहीं हुई इतनी ज़्यादा चीज़ है. And Dr. Veena Acharya, we all know, our own senior gynecologist from Jaipur, and a very affectionate person, teacher of teachers. She is ex-professor and unit head of SMS Medical College and currently chairperson of Indian College of Maternal and Childhood Health, NARCHI. And she has held many posts. And we know her because she's there with us in almost all the meetings, academic meetings we do in Jaipur or even outside Jaipur. So although she has not yet joined, I think she'll be joining very soon. And Taru Chaya, my friend and sister and colleague, and for whom we all depend on her enthusiasm for all the meetings and all the activities. She is consultant and director at Bansal Hospital, Shyamnagar, honorary secretary of NARCHI State Board, West Zone coordinator for Breast Committee Foxy, vice president NIGF, and a master trainer for Foxy RAC in Foxy HPV vaccination, and a member of all the committees here. Welcome, Dr. Taru. And finally, it is Dr. Mamta Gupta who has, I'm really thankful to her that she agreed to present her case at a very short notice. And Richa, would you now continue with the introduction of Dr. Mamta?
Thank you, Preeti Didi. Now I welcome, I would also like to especially welcome Dr. Mamta Gupta, who will be presenting today's interesting and educational case. Before this, I like to privilege and welcome our panel of experts with us today. Dr. Purnima Pachori. Roshanji, please. She is Senior Professor and Superintendent at Janana Hospital, Ajmer, ex-HOD, Department of Obstetric and Gynecology, Jail and Medical College, Ajmer, and experts in various fields. Next is Dr. Pratibha Singh. She is Professor and Head of AIMS Jodhpur since 2013, and she is expert in robotic surgery, Secretary of Rajasthan chapter of AGOI, and have more than 225 publications in international and national journals, and invite faculties in many conferences and workshops. We will be very grateful to welcome Dr. Pratibha Singh and Dr. Deepa Masan. She is Senior Professor and HOU of Obscene Gynec in JNU, President NARCHI of Rajasthan in 2022 to 2024, Vice President JOCS. Areas of interest is high-risk pregnancy, and she receives various awards and publication. Welcome, Dr. Deepa. And next expert is Dr. Taru Chaya. We already know, and she is our guide in day-to-day activities of NIGF.
It's over. अब आगे बढ़ते हैं.
So I request Dr. Bamta, please present your case. It is a very interesting case of residual ovarian syndrome. And friends, this platform is not just for listening, but it is for interaction, questioning, and collective learning. So I request all participants to actively engage in this discussion. Dr. Mamta?
Yes.
We welcome you.
Thank you, Dee. Thank you so
Please
much.
present your case.
Yeah, thank you so much. And good afternoon, everyone. Good afternoon, my all our teachers. And we have learned so much from you in day-to-day practice. We are thinking like past what our teachers were used to do. So that really helped us in day-to-day practice. So today I'm going to present in front of you an interesting case we met. I think we treated her 3 years back. And I'm going to present this case. Share. Okay, is it visible, Dee?
Visible तो
हम
है,
तो
पर
make it full screen.
full screen करना है.
Full screen.
ये एरो एरो है ना नीचे.
हाँ, ये एरो वाला ना नीचे.
हाँ.
हाँ ये.
अरे लास्ट में चला गया. Okay. So this is a case of residual ovarian syndrome. So there is a case, as we all met here, and I'm really grateful, and I think now I can also get some insight from you, all are my teachers, so that we can further enhance our practice and improve our practice part. So there is a female who was 36 years of age when she came to us, and with a lower middle class family. She presented in emergency and she complained very severe pain, abdomen, nausea, vomiting, loss of consciousness. Half an hour back, which she that consciousness lost it for a few minutes, and then she regained that consciousness. And if we took, when our emergency department, some resident officers were there, they took history. There was not any similar history in the past, no history of hypertension or any thyroid profile. Nothing was there. When they asked about the menstrual history, because she had already had the abdominal hysterectomy for severe adenomyosis 2 years back. And her obstetric history revealed that she was undergone two cesarean section, one 9 year back and other 4 year back. And after 2 years of last delivery, she undergone abdominal hysterectomy for severe adenomyosis. On examination per abdominally, there was tenderness on left iliac fossa, and when she was investigated for her blood profile, CBC, LFTs, and kidney function tests were sent because that took time. Meanwhile, a US sonography was done, whole abdomen, and that revealed a homogeneous hypoechoic cystic mass was seen in left iliac fossa. It's around 5.5 to 4.5 centimeter. And the color Doppler study of that mass, that cyst was normal. They was not reduced or any significant finding. And there was minimal POD fluid was seen. Other test reports were awaited, but in due course, they were found to be normal. Looking at the severe cystic nature of query ovarian mass, they referred this patient to the OBGYN department. As this ultrasound has been shown that there was a cystic mass in left adnexa region. So in our department, we see there was a left tender mass per vaginally, but exact size or the stiffness or the nature of the mass we could not get. So our differential diagnosis was whether it was a simple ovarian cyst, it could be a hemorrhagic cyst, sometimes it caused pain, corpus luteal cyst because she is 36 years of age and still she is ovulating and hormonal profile could be normal. Could be endometrioma. It could be any benign or malignant cystic mass origin, we don't know. And not but the least, torsion of the ovary, that is our probable diagnosis. But because the color flow of the cyst was looking normal, there was, as we know, that torsion of ovary, the flow of the vessel is quite reduced, rather absent. So we went into a diagnosis of residual ovarian syndrome because her ovaries were left during the time of abdominal hysterectomy. And both three surgeries were abdominal. It were not laparoscopic removal. Three surgeries were abdominal. So we were thinking of most probably it's a residual ovarian syndrome because of certain additions. That was our first diagnosis. So we started her on conservative treatment on IV antibiotics, painkillers, antiemetics, and simple fluids. In due course of 2 days, she got partially relief with all the symptoms. So we did a sonography after 2 days. What we found in our TVS that by probe when we inserted through the vagina, there was the tenderness over the left adnexal region. It was less than it was before on the day of admission. The size of cystic mass is also reduced. The fluid which we found in the previous sonography, that also got reduced. And the color Doppler study was similar as before. But again, on third day, she developed intractable pain, very severe pain on left iliac fossa. So looking at her condition, we immediately decided to take her for an emergency surgery. And because we were suspecting abdominal surgeries and multiple adhesions, we only decided to open her by laparotomy, not by laparoscopic surgery. So what we found during surgery, there was dense fibro adhesions in pelvic area and in lower abdominal area. And when we saw at the left side of the adnexal area, the left ovary was deeply adherent between bowel mesentery and left iliac fossa, the bony wall over the peritoneum. So in between all these structure, it was stuck. And with difficulty, we tried to release it, but it profused started bleeding. So we have to remove it because there was no other options left with us. When we saw towards the right ovary, that was also adherent toward toward the pelvic brim of right near ureter. So what we did in that surgery, we tried to save that right ovary and we repositioned it and we just kept it little bit away and toward the abdominal area. Right, we remove it, we repositioned it above pelvic area. Post-operatively, we observed her and uneventful. It was for next 2 days, and then she was discharged. And for next 6 months, we followed her up and we found it was non-significant. There was no recurrence of any symptoms. So our diagnosis made was residual ovarian syndrome. And what this residual ovarian syndrome, as we know. So these are the retained ovaries, usually after hysterectomy, and which in due course cause pain or develop masses. Incidence, if we see, it's around 2 to 3%. But most of the cases, it has been seen that in coming 5 years, 46.6% of cases, if they can develop this residual ovarian syndrome. And in due 10 years of case, 75.4% of cases following the surgery. And most of the time they require surgical intervention. So what these residual ovarian syndrome, these residual ovaries, how they present in our OPDs usually. So these people, they come with pain. Around 76% of people, the females, they come with pain. And why? Because due to increase in size because even if they are perimenopausal age or in the reproductive age group, the chances of getting follicular cyst, simple cyst is very common, as we know. So once they develop cyst, and because there's no surrounding capacity, if there are multiple adhesions around it, say there's no surrounding capacity to hold that volume, that causes acute pain, and that acute severe pain sometimes leads to vasovagal syncopal attack. In these patients, if not severe, they may end up in a cyclical pain, chronic pain, occasionally sometimes seen bowel and bladder symptoms. Sometimes these residual ovaries seen as masses, around 22% of cases, and dyspareunia in around 67% of cases. So what is ROS? Hello. So residual ovarian syndrome usually happens when ovarian tissue is left behind after surgery, usually after hysterectomy or attempted oophorectomy. And this leftover tissue, sometimes which are hormonally active, they form cyst, leading to symptoms. And why it happens? Because of dense pelvic adhesions, sometimes because of multiple surgeries, from endometriosis, previous infections. Sometimes that removal is very tricky during time of surgery, so we leave the tissue of that ovary or the incomplete removal of the ovarian tissue. Endometriosis also, if it is there, that include ovaries. And sometimes it's difficult anatomy or bleeding during surgery that tiny fragments left behind. So it has been seen that best method to see how to diagnose it is to see by ultrasound, that is 3D ultrasound, if possible. I don't think that is work well. CT and MRIs also are very good mode of diagnosis. Sometimes we can assess by estrogen levels for the active hormonal active ovarian tissue. And if not, then diagnosis can be confirmed by laparoscopy also. So in so many papers, what we observed, even our practice in onco department, it has been seen when ovariopexy is done during radiotherapy for CS cervix, they used to keep this ovary outside the pelvic area because of radiation. And even after 5 to 7 days of that away from the pelvic area, the chances of getting this adhesions are get reduced dramatically by 40 to 60%. And why it is so? Because it has been seen that ovary is the only organ, or I should say the tissue of ovary is the only organ which is covered with coelomic epithelium in our body. And that coelomic epithelium is very fragile in nature. And that is very prone to develop adhesions. So ovary, if it is left behind in surgery, during surgery, it is more probably, it is the most possibly it will get adhesions surrounding it, and it will stuck into that pocket, and later it may convert into a residual ovarian syndrome and land up in an emergency department. So what are the key points? So it is uncommon, but it real, especially in women with severe endometriosis or adhesion. Symptoms can appear months to years after surgery. Definitive management usually requires experience and minimally invasive surgery, not always the open surgery. Better to go with laparoscopic surgery so that we can at least save these females from further surgeries. What are the treatment options for these patients, like who developed residual ovarian syndromes? They can be treated once hormonal suppression by GnRH analogs, but those are very temporary and with side effects, as we know. But definitely surgical. Careful laparoscopic excision of the residual tissue is the best one, and it should be the best long-term solution. And the best one is the reposition, because most of the time, to avoid neck surgery, many of our gynec friend or many of the fraternity, they used to remove ovaries in earlier age, before 45 or before perimenopausal even, so that we can avoid neck surgery if something happens to ovary. But we should counsel patient all pros and cons of removing ovaries first. And if possible, we can reposition and anchor these ovaries or tissues outside the adhesions area so that further surgery can be omitted. Thanks. Thank you so much.
I just wanted to ask one thing. I think I missed it in the beginning. What was the age of this patient?
She was 36 years of age.
And she had this hysterectomy 2 years after her last childbirth.
Yeah, ma'am. She was initially operated 2 cesarean section for 9 and 4 years back, and she developed adenomyosis. The uterus was very big. We tried everything with medically. I think she was not land up with us initially, but she was tried with medication also initially, and for adenomyosis. But she didn't relieve it. She didn't relieve, and later on, she was very missed. Years long, those cells say she was in very pain. So she finally only came to us. So
it could be endometriosis all along, no?
Be endometriosis, because adenomyosis also there, so it could be an endometriosis. But the tissue biopsy came not when we confirmed that biopsy of the ovary, the left ovary, it was coming normal. That cyst was normal only. There was no endometriotic tissue before.
ये अनशेयर कर लो उसको।
स्टॉप कर दो, स्क्रीन शेयरिंग स्टॉप कर दो।
इसको वहां रख दो, तुम जाओ।
थैंक यू डॉक्टर ममता। डॉक्टर पूर्णिमा।
Hello.
प्लीज अनम्यूट। या
Dr. Pratibha, you want to ask something?
डॉक्टर
I
प्रतिभा।
was really surprised that this woman had a hysterectomy at the age of 36 years.
36.
That's a little
Yes.
Yes,
young,
yes.
specifically with the conditions of Government of India guidelines is being coming up that we should not be performing hysterectomy.
Now we can handle these patients by ICD, Mirena, or I think
Yeah,
many
definitely.
drugs have come in
Yes,
the,
yes.
so we can
Definitely.
manage
Good
these
drugs have
patients
come.
like this only.
Dr. Pratibha, but still in the remote areas, the hysterectomies are taking place as early as 30 years also.
Ma'am, very true. Very true.
Yes,
In fact, we can use these kind of platforms to advocate to everyone that this is
yeah,
not the right practice. And that is
yeah.
why I specifically had asked this question.
That is why
Because
we
we
have
should
We are
not,
started
not
this case
advising,
presentation.
but the remote physicians, RMPs who are quacks, they
Yeah,
feed in the patient's mind so deeply that
yeah.
yeah.
our counseling has no
Absolutely
effect.
true.
No, but
Absolutely true.
it never works.
Yeah.
Ma'am,
उनको
I
समझा के
completely
देते हैं.
agree with this, but still my concern is we can always use these kind of
Yes.
platforms to advocate what we feel is the right thing to do.
Yeah.
Obviously, they are doing what they want to do, but these platforms should always be used to advocate the right thing.
Actually,
Secondly,
we should not do. At
the
least
other
we should
comments
not
which I
do.
wanted to put here was, ma'am, sorry, I missed the last part.
There is
At
no
least we should not
guidelines.
do.
Nobody is following guideline. Huh? That is the problem.
Definitely.
Problem is the guidelines are there, but nobody is following. And who is taking care of it? I mean, like who's
Come
looking
second,
after these people?
we should not do this. We should not do. At least
No,
Let's
at least
discuss.
we should
Let
not.
us discuss
At
this
least.
case कि अपन इसमें क्या करते. Let us
yes,
discuss
yes.
because we just want to discuss in this कि when she was दो cesarean हुआ, उसके बाद adenomyosis query उसकी diagnosis बनाई गई for which hysterectomy was done.
We should
hysterectomy
residual
नहीं
ovarian
करी
syndrome.
होती तो अपन क्या क्या कर सकते थे. Let's discuss this.
Yes, yes.
डॉक्टर प्रतिभा आप बताओ.
Ma'am, इसमें the first thing is कि the other differential diagnosis besides endometriosis, I would also keep, though it is not very common, a supernumerary ovary. What happens is sometimes the women may have two, normally we already have two ovaries, one from on the left and one from the right side. But sometimes what happens is we have one extra set of ovaries. So even if we have removed one ovary, one ovary may be there. The second option is definitely the ma'am with the diagnosis which has already been made. However, in a case where we have the option of such good medical management for endometriosis, for adenomyosis, and so many conditions, maybe we could have put her on GnRH analogs. Maybe we could have put her on one of those long-acting progesterone that could have helped this woman avoiding the surgery. Sometimes it is possible that once you give the medical management, many of these women, specifically with the residual ovarian syndrome, they respond to these treatment. So that option is a chance. However, diagnosing residual ovary syndrome itself is a very tricky situation. The correct diagnosis itself is a very tricky situation, and many a times what happens is we may have to actually resort for laparotomy, like in this particular case as well. We have to resort to ovary to make a diagnosis. So
because
obviously, and whenever we do surgery for these kind of women, the surgery is definitely going to be very tricky, not only because of the disease, but also because she had now had multiple surgeries. So we have to weigh the advantages, the disadvantages, the pros and cons of going ahead with the surgery or trying with a short of a medical management. And that should be the best approach, I feel, specifically for these kind of cases.
Dr. Deepa?
Anybody?
Dr. Deepa, are you there?
My opinion is this कि इसकी सर्जरी शुरू उस समय एडेनोमाइसिस के लिए जो कि करना ही नहीं था. We would have given more treatment, counsel करके उसको, because she was already been done two cesareans. Additions
Mirena,
होंगे.
मेरे ना भी लगा सकते थे ना उस टाइम।
Ma'am, actually, what happens? It's not only this surgery. Suppose this is the one example we have in front of us. But in other so many cases, in so many, we don't know about how many cases has gone through matlab, and we didn't never diagnosed it properly. Like because she has come with the severe pain, abdomen, and so many complaints, vasovagal syncope, and so many things. Then only we have come into this conclusion and we have come into this diagnosis. But I think if percentage is too high, then there are definitely so many females that are coming in our OPD with pain and pain, chronic pelvic pain after hysterectomy, with left ovary or whichever ovary is
This
being.
is very important case you have taken, very good also, because most of the time when she has not yet completed 40 and hysterectomy has been done, तो we try to follow कि भाई एक ओवरी तो छोड़ो, क्योंकि उसका पूरा का पूरा अपन हार्मोनल सिस्टम्स क्यों हटाए. But later life के अंदर residual ovarian syndrome can happen, can occur because of many problems. It's not only endometriosis, many any other problems, adhesions, and also they can happen. So I think MHT पर डाल देना चाहिए उसको उस समय post op, so that
At the time of hysterectomy.
हाँ, because early hysterectomy की है उसकी ना,
हाँ.
तो अगर उसको हम MHT पे डालते तो शायद वो उसको ओवेरियन सिंड्रोम नहीं होता.
Could be अब ये तो मतलब but patients are very they don't think like HRT
मरीज
or
की
they
बात
don't.
नहीं सोचना चाहिए, हमको तो अपना सोचना है कि हमें करना क्या होएगा.
नहीं, but they don't. At least we have to take consent of these females whether they have to continue these medicines for a longer time,
You
and
have
they
to
are.
counsel them, not consent क्या लेने. वो तो हमारा ट्रीटमेंट है, हमने दिया, बाकी उन्होंने लिया नहीं लिया, that is other outlook.
No,
अगर
but I
हमें
think MHT and HRT के लिए we should have one consent paper and we should write down each and everything over it and let them
Is there
explain
any
and
need for
let them keep
is there
this.
any need for starting for taking consent for MHT? Is there any need? I
नहीं
don't
नहीं,
think so.
ये तो हमारा प्रिस्क्रिप्शन है, उनको फॉलो
Yeah.
करना है नहीं कर रहे, लेकिन हम तो ये देख रहे हैं कि ओवेरियन सिंड्रोम से हम कैसे बचाएं उसको, क्योंकि ओवरी वी हैव लेफ्ट.
Hello everyone, sorry, I was busy seeing some emergency patient.
दीपा,
So,
आपकी ओपिनियन क्या है? एक ऑपरेशन करके ओवरी छोड़ दी
yeah,
36 years की एज पर.
yes. So what I feel in this case, because day in and day out we are getting these many patients. Even I have got this patient recently in my OPD, as well as they were so keen to get the hysterectomy done even after the age of 25. Once they complete their family, they are insisting every time that you do hysterectomy whenever they are having any menstrual problem. And we do have one very effective solution for this is Mirena insertion or LNG IUCDs with us. And these previous 2 or 3 cesareans, once they are having menstrual problems, so we do have alternative procedure. Though our patients, no doubt, they insist upon doing hysterectomies. But this is us, we need to counsel them for the pros and cons of everything.
हो गया,
And,
अपन ने ओवरी छोड़ दी, एक हिस्टेरेक्टमी कर दी,
Residual
उसके
ovarian
बाद अपन
syndrome.
क्या करेंगे पोस्ट ऑप, ताकि हम वो रेजिडुअल ओवेरियन सिंड्रोम में ना जाए.
multiple pelvic surgeries के बाद, in fact, I have done some surgeries. In my opinion, I have seen so many peritoneal inclusion cysts. Even we have opened some cases even laparoscopically and open surgeries. So many a times we have opened thinking of ovarian cyst, but these come out to be peritoneal inclusion cysts sometimes along with a small ovarian cyst. So multiple surgery itself, they lead to such condition when the patient is having chronic pain abdomen. And residual ovarian syndrome, yes, no doubt. We are we are doing self-injectomy in all cases where we need to save the ovaries for her future, hormonal protection and everything. So in these cases, though it is very rare, but prevention, I don't think there is any prevention, just to
साइक्लिकल थेरेपी से नहीं
save the
प्रिवेंशन हो सकता.
uterus.
अगर हम साइक्लिकल थेरेपीज दें उसको पोस्ट ऑप, क्योंकि
Cyclical-
जल्दी हमने की है सर्जरी, वी
if
नो
your
इट
ovaries
36 में.
ओवरीज छोड़ने का फायदा क्या हुआ? अगर हार्मोनल ट्रीटमेंट ही देना है तो ओवरीज निकाल के ही दे दो। ओवरीज छोड़ते तो इसीलिए है ना कि वो
नहीं अगर
नेचुरल हार्मोन्स हैं
अगर
बॉडी।
सिर्फ ओवरी में ही है, इन दैट
नहीं
केस तो
मैम,
कुछ साइकिल्स हम
अनटिल
देके
अनलेस
बंद कर
डायग्नोसिस
सकते हैं।
नहीं
ma'am,
मतलब
we
ओवर
can do one
शायद
thing. Huh.
हम्म,
Ma'am, what I think we can do one thing. Like these patients who had undergone previous multiple surgeries, and we are now doing these early young reproductive age group female surgeries. We can reposition or anchor these ovarian tissue somewhere up in the abdomen, because that maybe the lower in the
How it
pouch,
that is true,
how it
but at
helpful for
so that we can prevent these additions and these residual ovarian syndrome.
नहीं, residual
That's the
ovarian
best.
syndrome
ओवरी की वजह
can be
से तो
because
नहीं
of
है।
cyst also, na? Can be because of cyst also. This can
हाँ,
be
उसको तो क्या है,
prevented by
इतना ही कर
So
सकते हो ना,
like
यूट्रस
lower
यूरेटर से
pelvic,
थोड़ा दूर कर लोगे और ये सब कर लोगे, इसके अलावा तो वहां तो छोटा ही पड़ेगा ना, कहाँ तक खींच के लाओगे।
नहीं
हाँ,
ओवरीज
नहीं,
अपन
इस
रिपोजिशन तभी
लिगामेंट,
करते हैं
ओवेरियन लिगामेंट को थोड़ा सा इन्फंडिबुलो pelvic लिगामेंट को नीचे पड़े रहने के बजाय वी कैन पुट कीप इट अप एंड वी कैन एंकर इट.
It can
दैट
be
विल
because
डू।
of cyst also, na? Ovarian cyst, hemorrhagic cyst. It can be because of residual ovarian syndrome. Can be because of this also,
So
na?
that's the problem, is the space. Problem
It
is the
is not
space,
so
because that is
easy.
very congested and
नहीं
very
नहीं
हाँ,
नहीं
that's
brilliant
the
space.
प्रॉब्लम
yeah,
इज अ डिजीज ओवरी। इफ यू पुट इट एनीवेयर एल्स हाउ डज इट मैटर?
yeah.
इफ देयर इज अ
It
प्रॉब्लम
is
इन
not
द
so easy
ओवरी
to reposition a structure up, as it is easy to
Yes.
speak about it.
नहीं, पर वैसे
And
भी अपन उसको
sometimes,
इनफर्टिलिटी केसेस में करते हैं व्हेन वी नीड द ओवा।
हाँ,
Yeah.
इनफर्टिलिटी में तो
उसके
वी
लिए
कैन डू ना, और
हाँ
इवन आई
उसमें
थिंक
करते हैं,
जो
But
कैंसर
सिर्फ
once
अपने को ओवरी में से
डिपार्टमेंट है,
ओवा चाहिए।
everything
दिस इज
is
द
out,
डिजीज ओवरी।
it is very difficult.
and sometimes in cases of severe endometriosis, we have to leave this
Yeah.
tissue because of adhesions. How we can
no, but
deposit it
if
on?
we anchor it in up in the little bit up in the pelvic, away from the pelvic
वो
area, at
वहां पे
least 5
How?
to
एडिशंस बना
7
देंगे,
centimeter.
ममता, डॉक्टर
No,
ममता, वो
how?
वहां पे एडिशंस बना देंगे, वो तो
And
प्रॉब्लम
ma'am,
तो
एंडोमेट्रियोसिस
ओवरी
तो जहाँ होगी वहां होगी ना, स्किन के नीचे
नहीं,
भी हो
वो
जाता
तो
है,
अगर
सही है।
एडिशंस वहां
बिकॉज
बन
ऑफ
जाएंगे।
एंडोमेट्रोसिस हम उसको निकाल ही नहीं पा रहे वहां से, तो हम उसको कैसे डिपॉजिट कर पाएंगे?
see, हाँ, those
Because
cases, the
only
difficult surgeries of ovaries, like what we are doing, we are leaving it like anything because she is 36 years of age and somebody left it. Okay. But those endometriomas cases or infective cases that where it is already stuck at the time of
Yes.
abdominal hysterectomy, then definitely it's a difficult thing.
हाँ,
But otherwise
Dr.
cases,
Mata,
we
it
can
can
put
be
it.
done only where the ovary is, whenever the patient needs chemotherapy or a brachytherapy where we are localizing. In that case, some of those cases we are repositioning, or in case of, oocyte, sometimes the fallopian tubes are removed. In case of IVF, in that case also we are not repositioning it. But yes, it is in practice of some of the surgeon, but it's not very helpful in cases of wherein residual syndrome per se.
Yes, ovary has to be healthy for it to be repositioned or saved. So if that is missed during surgery
The
and we are leaving
healthy
an
ovary
unhealthy
only.
ovary,
Of course, the healthy
the
ovary
healthy
only
ovary
should
left,
be repositioned.
yes,
Rest
healthy ovary
endometriotic,
left
infective,
behind,
whatever should not be
it has to
repositioned.
be removed. And
बट
if healthy
हेल्थी
ovary
ओवरी
left
भी तो
behind,
आगे जाके ओवेरियन सिंड्रोम में कभी भी कन्वर्ट तो हो सकती है।
वो अनहेल्दी हो जाए
yes.
तो बात है।
Previous multiple
If
surgeries,
But still,
if it
मतलब
is
like
there, if
at
we think
least
for a residual ovarian
at the
syndrome,
age
we
of
can also.
at age of 36, I don't think we should be removing the ovaries in any way. मतलब like if we can save the ovaries, why should we remove the ovaries at 36?
दैट
रेजिडुअल
इज
हो जाएगा
करेक्ट,
तो हटा
दैट इज
देंगे।
करेक्ट, वी शुड नॉट रिमूव ओवरीज, बट वही प्रॉब्लम है कि आगे जाके ओवरीज जो कभी भी
जब हो जाए तब कर दो, यही है, नहीं हो तो नहीं हो। बस आप ओवरीज कैसे हटा दोगे 36 पे? अगर मान लो उसको कोई प्रॉब्लम ही नहीं है, 2 साल का छोटा बच्चा है, ओवरीज कैसे हटा दोगे? अगर ओवरीज में उस टाइम कोई बीमारी नहीं थी एंड वी हैव नॉट मिस्ड इट, अगर उस टाइम की ओवरी में कुछ था एंड वी हैव लेफ्ट इट, देन तो ऑफ कोर्स
मेरे ख्याल से तो
इट्स अ प्रॉब्लम।
पेशेंट्स दे आर नॉट अग्रीइंग टू गो फॉर an alternative treatment technique. Otherwise,
यस
there is no need to do hysterectomies in these cases.
आई थिंक शी शुड
हम
these
लोग
are
बचाते
patients
हैं ना,
only.
समझाते हैं, मेरा ना लगवा लो ये, तो दूसरे कहीं दूसरी जगह जाके स्टेट में करवा लो।
दूसरी जाके,
It's
that
very
happens
difficult to
actually, that
counsel them.
happens.
It's very
So what
difficult.
everybody is doing, ki let
एक्चुअली
we do it.
अपन सबका एक का नहीं है ना कि भाई हम सब एक ही भाषा बोले।
हो नहीं सकता।
Yes. Hey, at least we should
So
not do it. Ragini ma'am, Ma'am is not there.
अरे वो एक और जगह पे चल रहा है ना सेमिनार वेबिनार। डॉक्टर दीपा,
हाँ जी।
अगर हेल्दी ओवरी छोड़ी थी और आफ्टर 10 इयर्स एट द एज ऑफ 46 पता चला है कि उसको तो वहां पे प्रॉब्लम हो रही है, डिस्परोनिया हो रहा है।
देखो प्रैक्टिकल बात तो ये है कि अगर ओवेस्टेक्टमी के साथ ओवरी
प्रैक्टिकल
छोड़
बात
देते
तो
हैं
यही है कि
दो
ओवरेक्टमी
तीन
कर
साल
सकते हैं, बेस्ट
नहीं
ट्रीटमेंट
दो तीन
Before,
साल बाद
before,
ओवरीज अपने आप फंक्शन
before,
बंद हो जाता
before,
है। ये नहीं देखा आपने?
before going for surgery, we should start medical treatment. We can try medical treatment.
No doubt, if she is relieved from her medical treatment, whatever we are giving her, and there is no risk, bilateral salpingectomy has already been done. In that case, ovaries can be left. But if she is coming with the recurrent symptoms and she is having like that much severity of symptoms that is affecting her daily routine life, even after medical treatment, in that case, that is the best treatment to do the surgical oophorectomy, right?
निकालो
बट
उसको।
व्हाट आई आल्सो फील
निकालना ही है,
कि
बहुत
अगर
लोगों में निकालना पड़ता ही है। वो पोस्ट आती हैं, ओल्ड भी आती हैं, इवन एट द एज ऑफ 65 समटाइम्स दे कम विद बेनाइन सिस्ट इवन, तो निकालना ही
Yes.
होता है उन्हें।
Initially, we can start with medical treatment, and by the time that cyst went off, and if it doesn't appear again or the space is okay enough for the ovary, maybe there is no further plan. Maybe there is not requirement any surgery. But if it reoccurs or reappear the symptoms or the severity, then there is no other way. We have to remove that ovary
एट
only.
द
That's
एज ऑफ 65 अगर वो 10 सेंटीमीटर 12 सेंटीमीटर की यूनिलोक्युलर सिस्ट भी लेके आती है, इन दैट केस यू
So
जस्ट
we
कैन
have
नॉट
to go for
से।
surgery.
हाँ, टॉर्जन होने का डर तो पूरा ही है ना।
हाँ बिल्कुल, वो तो
चलो
करना ही
Torsion
पड़ेगा।
एक चीज बताओ, सपोजिंग दिस पेशेंट वाज एज ऑफ 50 और आप एडिनोमाइसिस के लिए चेक नहीं कर रहे थे, तो ओवरी हटा
आपका
कर रखोगे, क्योंकि ऐसे कहते हैं कि ओवरीज में
तो
से
कर ही देंगे,
ईस्ट्रोजन और
उसी
स्टेरॉइड्स
टाइम
हो तो 60 इयर्स तक भी रहते हैं बॉडी में। एंड एडेनोमाइसिस में अगर ओवरीज नॉर्मल है तो भी 50 पे निकालोगे या छोड़ो?
50 पे तो निकाल ही देंगे ना।
निकाल देंगे।
क्यों छोड़ेंगे?
45 पे,
वो तब भी
मैंने
कहते
तो
हैं
कट ऑफ
इट्स स्टिल अ
45
सेक्स
रखा
ऑर्गन,
ही है।
बट इट्स स्टिल अ सेक्स ऑर्गन एंड इफ इट इज लेफ्ट बिहाइंड तो दे से कि उसके हार्मोन्स एंड एवरीथिंग ऑस्टियोपोरोसिस और सब कुछ चीजें प्रिवेंट होती है उससे। जनरली वी डोंट
50 के
ऑफ
बाद
कोर्स
तो
वी रिमूव कर देते हैं, नॉर्मल ओवरी हो तो।
हाँ, मतलब ओवेरियन
नहीं,
कैंसर
अपना
बनने के
पेशेंट कुछ
चांसेस
ज्यादा ही
ऑल्सो।
समझदार है और वो रखना चाहता है तो अलग बात है, वो तो उससे कंसर्न ले लो, बट
लाइक
अदरवाइज
अब
हम
देखो,
कंसर्न देखो
हिस्टेरेक्टमी में अगर हम ओवरी छोड़ रहे हैं, आई थिंक उस समय भी उनको सारी चीजें एक्सप्लेन कर देना चाहिए ऑन पेपर्स, डॉक्यूमेंटेशन के साथ कि
हो
ये
सकता है
आगे
ओवरी
जाके
में ट्यूमर हो जाए और बाद में
हाँ
निकले।
बिल्कुल
हाँ
बिल्कुल बिल्कुल, we
ठीक
should do
है,
this.
अपनी मेडिको लीगल सेफ्टी तो बनानी पड़ेगी।
हाँ, पहले तो हमें अपनी स्किन ही बचानी है, उसके बाद सोचेंगे सारी चीजें।
हम लोग सर्वाइकल कैंसर स्क्रीनिंग वी डू टिल द एज ऑफ 65। आई हैव सीन रिसेंटली a very high profile patient of age 82, she came with CS cervix, so
हो सकता है
what is the answer for that? क्या कर सकते हो? तो वही वाली चीज है
भाई, आपकी
कि
स्क्रीनिंग को
आप
उसने बोला 65 तक ही करोगे, उसके बाद नहीं
हाँ,
कर रहे हो, क्या करो?
नहीं कर रहे, तो अब
करना
उस
चाहिए।
patient को तो वेरी हाई प्रोफाइल पेशेंट और
तो
इतनी
स्क्रीनिंग में
एक्टिव।
कौन सा पता चल जाता है सब।
हाँ ये भी है, बट एट द एज
बिल्कुल
ऑफ 82 she came with
नहीं,
metastasis all around the
पोस्ट
CS cervix.
मेनोपॉजल ब्लीडिंग के साथ तो आई होगी ना, कुछ तो कंप्लेंट किया हो।
नहीं, एक्सेप्टेड वाइड डिस्चार्ज 82 इयर्स पे आई है वो,
उसको
इतनी
रहा होगा
स्मार्ट लेडी, इतना सब
वो
कुछ, और
60
वो
ईयर्स
ऐसा कुछ कहा नहीं जो
60
उसने
ईयर्स से हो
कभी
रहा
छोड़ा
होगा उसको,
होगा।
60 साल से चल रहा होगा उसको, धीरे धीरे बाय तब
हो
पता
सकता
चला।
है, हो सकता है।
So ovarian cancer are silent.
ओवेरियन के लिए भी आप 50 इयर्स पे अगर सर्जरी कर रहे हो एंड देन यू आर लीविंग ओवरीज, तो आई डोंट थिंक दिस इज अ जस्टिस टू पेशेंट, बट इफ
गुनाह
शी
है,
इज
गुनाह,
इंसिस्टिंग कि
नहीं छोड़ना
But in
चाहिए।
उस
Delhi,
समय
not in Jaipur, but in Delhi, definitely they are very keen to preserve their ovaries, like at 50 also.
तो
नहीं
दे
नहीं
हैव टू साइन
हार्मोन से फर्क पड़ता
that 1%
Jaipur
chance
and
of
Rajasthan, so
ovarian
at least
cancer
we
is
can
there.
counsel them. At 50, there's no point. If it's losing, the ovary is going to lose her, it's all.
एनी हाउ, चलो 2-3 साल और बच जाएंगे, उसके बाद तो एग्जॉस्ट हो जानी है ना।
एग्जॉस्ट हो
तो
जानी है, बट ग्रेजुअल
Risk
ग्रेजुअल
of
मेनोपॉज
ovarian
आएगा ना।
cancer.
ऐसे तो कैंसर तो किसी भी ऑर्गन का हो सकता है, वी डोंट रिमूव ऑल द ऑर्गन्स ना।
हाँ
इस
खाली हो जाएंगे एक दिन।
ओके दी, वी शुड।
बहुत
Okay, I
अच्छा
think
प्रेजेंट किया ममता।
yes,
Thank
Mamta,
you,
nice
Dee.
It
case,
was a very
really
nice
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 case,
case and nice
case.
discussion.
and
Yes.
रिचा अगली
it all
अगली बार के लिए ना पहले से ही तय कर लो कौन सा टाइप का केस, एंड केस प्रेजेंटेशन ही करेंगे अपन लोग।
हाँ
दीदी अभी भी आप बोल रहे थे नहीं करो, फिर कर ही लिया ना 3 दिन में।
लोग नहीं थे ना, एकदम 2 दिन के अंदर करा ना अपन,
पर
इसलिए कहा था।
देखो, वी शुड बी ग्रेटफुल टू ममता एंड शी गिव सच अ केस कि अपन सब एक बार सोच तो रहे कि क्या करें ओवरीज का और क्या करें यूट्रस का, और हिस्टेक्टमी करें कि नहीं करें। नाइस, वेरी नाइस,
नाइस
थैंक यू
प्रेजेंटेशन
मैम।
ममता।
एक एक लाइन
थैंक
सबसे
यू मैम।
वापस ले लो उसके ऊपर। डॉक्टर प्रतिभा, डॉक्टर
Yes, ma'am.
पूर्णिमा,
Yes, ma'am.
आपकी क्या
की
ओपिनियन दीजिए।
मैसेज।
Ma'am, I missed the last conversation, ma'am.
कोई बात
जस्ट
नहीं, आप अपना दे दो कोई भी जो आपकी इच्छा
ठीक है
है।
दीदी।
Ma'am, I can only say, firstly, which I had already communicated. Firstly, this platform should be used for all the members that hysterectomy should not be done for such a young age. Secondly, we have got such good medical management for majority of the conditions that should be emphasized. And it always tells us diagnosing such a tricky situation of a remnant ovary syndrome. The person who has managed it definitely deserves a credit. A big applause to them, I feel. That is definitely to be applauded because that's not something very easy to diagnose and to manage. So that is my comments, and I must thank the organizers for having me here and sharing my views, my opinions about on this portal. Thank you so much.
डॉक्टर दीपा,
थैंक यू डॉक्टर प्रतिभा।
मेरा तो एक ही प्रिंसिपल मैंने बना रखा है, below 40 I do hysterectomies only for the condition which are if the patient is having a big organic pathology, structural pathology, and her uterus is more than 12 weeks size and it is not treated with the other medical management, then only I agree to do
2
hysterectomy in these
सेंटीमीटर के
patients.
फाइब्रॉइड पे ही तो कर देते हैं लोग।
हाँ, वही तो चीजें हैं, वी डू हैव, तो मेरी तरफ
We
से तो
need
फुल
to
काउंसलिंग होती
educate
है।
our students who will be
Yes.
spreading across the country. We need to educate
Yes.
our students for this.
करेक्ट
Yes.
करेक्ट।
but you know, madam, who is
For
doing the
residual
highest number
ovarian syndrome, Dr. Deepak, one line for residual ovarian syndrome.
We need to diagnose it, ruling out other pathologies, and try to treat, keeping all the differential diagnosis in mind. And then only, uh, if we are confused with the pathology and what is the cause for it, then a diagnostic laparoscopy is the first thing to look into it, whether these are peritoneal inclusion cyst or really an ovarian pathology. And tumor markers, no doubt, I agree to it. Whenever it is there, tumor markers are to be done in these cases, along with a good radiological imaging modality. And then only we should decide upon the treatment part, what should be done in these
Thank you,
cases.
Dr. Deepak. Dr. Purnima?
Yes, I really appreciate your effort for bringing us all to this platform and discussing as such a beautiful case, because
Thank
we all encounter such kind of cases in our day-to-day life. And at that time, like this case presented in a quite agony, and there was no option other than the surgery. So many times we have to do surgery for such cases, but I would disagree that we should not reposition it, because we never know in the future again what will happen. So once we have opened for the symptoms like acute pain, then we should remove the ovaries. We can put the patient on hormonal treatment after that. Instead of reopening again and again, we can put her on hormonal treatment. In the first go, we can save the ovaries. We can keep the ovaries during hysterectomy. But after that, if she comes in a diseased uh, form, then we have to remove. We should remove so that her further life is not ruined by the disease. This is what
Thank
I
you.
feel.
Dr. Taru?
मेरी ओपिनियन ये है कि इनकेस मेरे को अर्ली एज में हिस्टेरेक्टमी करनी भी पड़ी, कोई भी कारण हुआ, एंड आई हैव लेफ्ट ओवरीज, then I will counsel the patient and tell कि this may be a problem later on in life. And जरा सा भी symptoms कोई भी appear होता है, then medically manage करें अपन early so that she doesn't land up in such cases.
Thank you. Preeti Didi, now I invite Dr. Preeti Sharma for thanks.
So
प्रीति
thank
जी
you so
मेरे
much
इसी
everyone.
बात पे कोई कमेंट है क्या?
नहीं तुम्हारी बात पे नहीं, मैं तो ममता से एक बार वापस पूछना चाह रही हूँ. What her when she was saying that reposition the ovaries, it was at the time of the hysterectomy, no? Not later on. It was at later on.
Later on, at the time of
Right
laparotomy.
ovary was repositioned. We just put it and anchored in little bit above the
At the
adherent
time
or
of hysterectomy
adhesions.
बोल रहे हो ना?
नहीं, at the time of laparotomy.
At the time of laparotomy, when we did,
Then you had reposition.
we removed left ovary and
हाँ.
right was little bit, because that was also a little bit adherent to the ureter area. So
उसको
थोड़ा सा
reposition
जाके
करा.
we just anchored it. अब उसके बाद till now this was no complaint. So we didn't.
अब तो ओवरी चल रही है उसकी.
मतलब आपने ओवरी
that
निकाली थी
ovary is
उसके बाद?
working well.
लेफ्ट
हाँ, ये
ओवरी
मैं
डिसीज
क्लैरिफाई कर रही थी.
निकाल दी थी, राइट ओवरी को रिपोजिशन करते हैं.
रिपोजिशन कर दिया अभी.
राइट को.
Right. Yes.
डॉक्टर ममता यू वांटेड टू से कि वाया जब हिस्टेरेक्टमी करी उसी समय रिपोजिशन कर दें अगर अपन, तो ये स्टेज नहीं आए.
मैम ये कह रही हूँ, अगर इफ इट इज नॉट एंडोमेट्रियोटिक, इफ इट इज नॉट एनी अदर डिजीज्ड ओवरी, तो और
हेल्दी
अगर
ओवरी.
वी थिंक कि बिकॉज प्रीवियस मल्टीपल सर्जरी वाले पेशेंट्स जिनमें हेल्दी ओवरी है, दैट वी कैन रिपोजिशन, क्योंकि हमें पता है कि दीज पेशेंट दे डेवलप इन द कोर्स ऑफ टाइम, दे डेवलप एडिशंस.
हाँ करेक्ट.
So
सोचने वाली बात
not,
है.
हाँ, why not we
Nice.
save one more surgery? Why can't we do this? Or
Yeah.
it's not,
Nice
और 5
food
to
for
7
thought.
सेंटीमीटर का डिफरेंस आ जाएगा. That
If
ligament,
it is possible. If it
हाँ,
is possible.
if it is ovary and that is hanging, that ovary is hanging down, rather than we put it up. So there is a gap of 5 to 7 centimeters, and that's quite enough to save these ovary from adhesions. Why not? एक स्टिच, वो सारा हम ओवरी तो नहीं होता है ना, वो इनफंडलो पेल्विक लिगामेंट से अटैच्ड होता है. सो इतना गैप तो हमें वो भी मिल जाएगा.
के पास ओमेंटम वगैरह लगा दे तो?
हाँ, वो भी कर सकते हैं मैम, उसकी सराउंडिंग में.
हाँ, तो उससे क्या होगा, ओवेरियन फंक्शन तो पूरा रहेगा, एडिशंस नहीं बनेंगे.
So thank you so much. Real good food for thought. Huh? I will be leaving now. Thank you so much. Yeah.
Thank you, Dr. Taru,
Thank
Dr.
you all.
Purnima,
Thank you for
Dr.
involving me.
Pratibha, Dr. Deepa, for a nice discussion. Thank you, Dr. Ragini ma'am.
Thank you so much, Richa, for
Thank you.
being strong on me. Thank you so much.
Thank you, Didi. Okay, bye.
Okay, bye bye.
Bye bye.